So if you guys haven't watched the first episode with Dave, go do that now. There's a ton of information in there. We really focused on what to do before ever thinking about testosterone, all the things that I don't think it talked about enough, what I call cleaning your house and checking off the boxes. So the nutrition and the sleep. We got really into spiritual health and emotional health, which was really cool too. So check all that stuff out, because that was the prerequisite to this course, which will now be Testosterone 101. I kind of will coin it. We'll talk a little bit about when to go into TRT, why somebody would go in on TRT, and how to do so. So Dave, maybe to start out, we can talk about why somebody would go down TRT. Maybe we can describe first, what is hypogonadism or low testosterone, and is that the only time that somebody would need TRT?
Okay, this is a good question, because this is now I'm just going to rant for like 20 minutes. So
yes.
Firstly, I don't think anyone objectively needs TRT. You need cortisol, and that's about it. You don't need any other hormone. You can breathe and survive without testosterone. So I don't think anyone technically needs it, but I think way more people than they realize could benefit from it. And that's how I would preface this. So, and I think you have a sliding scale of how much you would benefit from it based on how low your testosterone is to begin with. I just think that there is a spectrum of people above the hypergonadal cutoff that would benefit from it. And this is why. I think, and this is just my perspective, and people can disagree, that there are points that you get to in life where you get off track, or you have a problem that you can't overcome and you need an intervention. And I think it's cool that these days there's less stigma around speaking and saying, I'm at that point. And sometimes people need a therapist. Sometimes I think SSRIs are appropriate for a short period. Absolutely. I think there are points where people need intervention. Sometimes that intervention is metformin. Sometimes the intervention is a personal trainer. And I think sometimes if you get to a point where you're like, I need an intervention, I think that there is a case for going, okay, maybe increasing your bioidentical natural testosterone level to what they could be a healthy level, even if they're not technically low enough to begin, or technically in that hypergonadal range. Maybe that would be better for you in terms of what you're trying to achieve, but also your health outcomes, than Vyvanse or methylphenidate or Zoloft. I think these are discussions that people should look at. So I think that men should be able to, or at least be open to having a discussion around augmenting their testosterone levels, assuming they understand that they know they're making a lifelong commitment and there's complications and all these different things. I think that that's one category. But with that said, the whole other part of this conversation, which I think is also worth looking at, is that I don't think it should be your first resort option. I think it should be the bazooka in the back pocket, because there are so many things that you should do first. And if you go on TRT, you're going to have to do all those things anyway, but these things are way less invasive, right? And they're all the things that we spoke about last time. So I think coming back to the original question, I think when you should look at TRT, or why you should look at TRT, is at the point where you need an intervention, because you can objectively sit back and assess what's going on and saying, I need assistance to achieve what I'm trying to achieve. I'm not doing well. And then I think that testosterone should be looked at as one of those interventions. You should be going to your doctor and saying, hey, I don't feel well. And rather than walking out with a SSRI script, you should be walking out with a blood test and maybe a referral to a therapist of some sort, or maybe a personal trainer, like all these different things you can do. And I think testosterone should be on that table, but it's a highly invasive thing to be doing. So it's a big commitment.
Right. Yeah, you call it the bazooka. I tell patients all the time, it's the nuclear approach. That's the one that we can't really go back from. So let's try to exhaust all conservative options first. If none of that works, let's move on to the nuclear option, the thing that we can't really go back from, which isn't fully true. And maybe we can get into that a little bit later too. But something I definitely want you to kind of tease out for us is, do the readings on the labs really matter? So, is it after a certain threshold, say below 300, you absolutely need testosterone, or if you are above 500, you never need testosterone?
That's a very good question, Ben. And I like these questions because they're really, it depends on who you talk to answer. And I think that because there is not a consensus on what is technically correct here in terms of we don't have that actual hard evidence, I think there's a lot of different answers to this question that can be entertained. So personally, I'm a blood work guy as much as I am interested in symptoms. I don't like this idea of It's not about the blood work. It's about how you feel. I think that that's taken out of context. I think that that's when you're only myopically looking at one blood value. And I think that that's very true. One myopic blood value doesn't mean that much. But comprehensive blood work, I think, is more important, if not just as important, as how you feel. Because you could go and take 500 milligrams a week of test, do a bunch of lines of coke, have some Jaeger bombs, and you would feel fantastic. But your blood work would look like shit. So like we have to look at this point and go, oh well, it's all about how you feel. It's like that's the narrative in society that we're getting pummeled with these days. But that's not science. Science is I want your comprehensive blood panel, and I also want to know how you feel. It's a balance. So the thing I like about checking testosterone levels is that I like to at least match their symptoms to their testosterone levels. So we use different units in Australia. So I'm sorry if I'll speak relative to the reference range for the sake of the conversation. Now, reference ranges are not the ranges for health. I know that, just for people who are, the reference range is bullshit. I know, but we'll just speak relative to reference ranges. So if someone is in, let's say, below the bottom of the reference range for free testosterone, that's low. Like that, to be at that point in 2023, you are low. So if you're at that point and you're like, I can't get out of bed in the morning, I feel fucking terrible, like I'd be like, okay, that makes sense. But if your free testosterone was, let's say, just like at the top of the bottom half of the range, and you're like, I can't get out of bed, I want to put a gun in my mouth, I can't build muscle and all these different issues, I'm going to go, well, you shouldn't be thriving with this level, but you shouldn't be feeling that bad. So there might be something else that we need to look at. Other systems of blood work, maybe they're more hypothyroid than low testosterone, or maybe their diet and lifestyle is just fucking trash, or maybe both. And that's something that needs to be looked at. So I like bloods in the scheme of comprehensive panels so that I can see what's going on. I don't think that there is a hard number that it's like below this you need TRT and above this you don't, because we've got androgen receptor issues. And there's quite a few doctors who've spoken about this. I know that Keith Nichols has a video on it. I know other doctors do. I just can't remember who else has them, but you can search that up for androgen receptor resistance. But we can't check the receptor profile of an individual without doing an autopsy, and you're not going to survive that. So we can't do it. And I like to describe testosterone or hormones in the body like an old school pinball machine. So for the people who are too young, we used to have physical pinball machines. And when you play pinball, the ball flies around, but you don't get any points unless it hits the bumpers. Hormones are like that. They don't do shit until they activate the receptor. So we can't test how your receptors are working, and we don't fully understand what's fucking up people's receptors. So the higher someone's testosterone is, the more I'm going to look for other things that could be causing their issue. The lower the testosterone is, I'm not going to completely disregard everything, but the more I'm like, okay, let's be a bit more gung-ho with this approach, because if it's not the testosterone issue and you put them on testosterone, you could make the problem worse, or you might have just signed them up for a lifelong intervention for something that wasn't appropriate.
Yep. Yeah, I love the mix of the two. That's exactly how I look at it too. I think that being too dogmatic about lab work only is, not great. So I have guys sometimes who come in and they have, a high 300 nanogram per deciliter. So for those US people listening, or outside the US, you would know that's almost to consider classic, medically hypogonadal. Sometimes like, I feel great, man. They're putting on good amounts of muscle. They have a great libido. I assume that potentially that's more towards the androgen receptor side of things, and their, genomic response and their transcription. Maybe they don't require a lot, because they feel good. And that's maybe all their physiology requires, and more may just put them into sympathetic overdrive and cause a host of issues. And then conversely, sometimes I'll have a guy who has a 500, which would be smack dab in the middle of normal, and they feel awful, and maybe they require more. And, a lot of these guys, they're 40, and what's to say that 20 years ago, they didn't have a 1000 nanogram per deciliter. So they have a 50% decline. It makes sense that they're not feeling optimal, So starting with lab work early in life is great, I think, too. So you have a reference to look back on so that you can continually gauge your symptoms with your lab work throughout the years, because it's an art of melding the two of symptoms and lab work. And like you said, we have this new group that I never look at lab work. I just go solely off of how the patient feels. Well, that's absurd, especially because testosterone and its side effect or its effects or the symptoms that would present can be kind of linked under so many other things, things like I feel tired, I have low libido, like these. So many things can cause this. Like testosterone is one of probably 100 mechanisms that could be, irrelevant here. So why are we just blasting people with testosterone without even checking to see what their levels are?
Yeah, and it's it's symptom resolution is important, and there can definitely be reasons why someone needs more testosterone than another guy. Like I'm sure that you guys have got similar things. Like I'll speak about the reference range. I've got guys where if you take their free testosterone to about the top of the reference range, they feel fantastic. If you take it to double the top of the reference range, they, like, as you said, sympathetically dominant. I call it cranked. I think that's a good way to describe sympathetic dominance. It's cranked.
Yeah.
It's like you're on, but it's a bad kind of on. It's like that's what it is to be cranked. But other guys, like myself, like I'll be very open about my levels. Is like I need to be closer to double the top of the reference range to get the same response as them at the top of the range. And then what I also think is important, which a lot of people don't look at, because previously, andropause was the only thing that we were treating with TRT, which was for older gentlemen. I just don't understand the idea of treating a 20-year-old and treating a 60-year-old with shooting for the same levels. It makes no sense. And I think that needs to be taken into account. Is like, if we've got younger guys coming up who are 21, 22, they're probably going to need more testosterone than a 40 or 50-year-old guy. Now, there might be exceptions to the rules, and there absolutely will be. But I also think that with the younger guys, there's a double whammy, because we grew up with more plastics. We grew up in a more polluted environment. We grew up with poorer diet and lifestyle patterns, and the younger generation are only worse. I mean, I'm 30. The guys coming up who are 20, they're really problematic. So if anyone's going to have androgen receptor problem, it's also going to be the younger guy. So I'm not surprised when I see people who are, born in, let's say the 1990s versus 1980s, who need more testosterone levels to resolve their symptoms. So I think the blood work is important, but the blood work is important in context. Like we need to know where you're at, because there are testosterone, and this is a thing that I know that guys get caught up on this, and I don't mean to sound patronizing to guys who feel this way, because I understand it, but like testosterone is not the only barometer for your subjective experience of being alive. So I made this analogy the other day. I said, if you get up in the morning and you drive your car bad and your car doesn't drive right, you're not going to pull over and start ripping shit out of the bonnet and changing this and that because your car drove badly that day. So just because you woke up for a few days with a lower libido and a lower erection quality, or you needed a nap after lunch, it's probably something to do with life. And the testosterone level optimization should be left to your practitioner who's sorting things out, and you should just take your medication as it's prescribed.
Yep. Yeah, it's an interesting thing. And I think those of us who have been on TRT or even TRT plus, steroid use, we know that testosterone is not the end all be all. I mean, full, just being very transparent. Last night, I felt like my erection quality wasn't great. When I was with my wife, I'm like, I don't know what changed, but my testosterone certainly hasn't. I know my testosterone's dialed in. Probably the fact that I didn't get good sleep the prior night, and I probably was dehydrated because I just worked in front of a computer all day and forgot to drink enough water. There were so many other variables. And so, just jumping straight to testosterone, I know it's super sexy. But it's really nothing that special is what I try to tell people. Yes, it can be amazing, but it's also really overhyped. And most people will be disappointed if they're expecting it to be miraculous.
Yeah, and absolutely. And I think that's one of the biggest causes of this gap between expectation and reality with TRT in terms of how much of a override it is for other things. And it's really not, because it's working with you, not on you. And I think that's a fantastic point, is that people need to be really, I like to look at testosterone as a multiplier. And I think that looking at it a multiplier is really good, because if you eat a good diet, you're going to get, 1 point from that to make you feel better. But if you eat a good diet and you go on TRT, it's going to multiply the effects of that, because your body's going to be able to utilize the nutrition better. But the thing is, I don't think upping the testosterone dose ups the multiplication integer that we're talking about in terms of degree we're multiplying it by. I think you're just stuck with, let's say, a twofold multiplier. But the variables that you can fuck with are on the other side. That's the stuff which is like the diet and the exercise and the good sleep hygiene and the mobility work. And I think that these things all go further when you put the TRT in. And I think that if guys can look at that and go, okay, let's start ticking off these boxes. And I think if you imagine that each of those categories or those areas of life, and people have got different definitions for it, and people can look up different people's perspectives. I like Paul Chek's one. I think Paul Chek's one's really good. I think they've all got diminishing returns. So I think rather than just maxing one area out and neglecting the others, you want to invest in all of them. Kind of like on RuneScape, you want to distribute your points equally between all your skills. And then once you have the bases covered, then you can max out your fishing, or then you can max out this. Like, you can do that. But I think that's where people are going to get the ROI, and they're wasting life force and energy trying to out milligram the kilograms of the other stuff.
Yeah. So we've touched a little bit on symptoms, and we said there's a lot of carryover to other issues, but what are some classic things that you see that put you, or that you raise suspicion in you that this person may be dealing with low levels of testosterone from a subjective side only?
That's a good question, because as you know, there's a lot of other things that will cause hypergonadal symptoms. I mean, hypothyroidism and hypogonadism are almost like a completely crossed Venn diagram. The symptoms are mostly, when you look at male hypothyroidism especially, they're very, very closely related. Inattentive ADHD is a big one as well. If you look at low testosterone symptoms in inattentive ADHD, I mean, if you put inattentive ADHD, major depressive disorder, generalized anxiety disorder, social anxiety disorder, and psychological erectile dysfunction, you can basically just pull out the different text lines from them, and then you have the hypergonadal diagnostic criteria. So I think how it's going to express is going to be different for different people, and I also think that the degree of the priority that people place on different things will have a different degree of importance. So some people will fixate on the function of their penis. Some people will fixate on things like brain fog, especially people who work in sales or people who work in high-profile jobs. Some people will fixate on the fact that they just, the classic one that you hear is like, if you properly train and do your diet properly, assuming that that's a factor, when you bulk, you get fat, and then when you cut, you lose muscle. That's a really good one to be like, that's that. But it depends in younger or older guys. But generally it's this, I think psychologically, I think learned fear is the symptom that I see the most, which people would call anxiety in various aspects, but it's chronic state of learned fear. I see people psychologically default to their maladaptive coping mechanisms, which is either avoidance or neuroticism. They either try to run away from things and procrastinate, or they become obsessively hyper-controlling. I see that come up a lot in terms of people coping with the stress of life. I think life becomes more stressful than it should be. And I think that that's the main symptom. And then how you can't handle that varies differently based on who you are and your circumstances. But those ones, I guess a bit more esoteric. Sexual dysfunction. I think guys will generally go, hey, my sexual function is not as good as it should be relative to how well I'm looking after myself. And I think that with some mental health stuff is usually the stuff that comes up first. Or for the professionals, it's the brain fog.
Right. The sexual health is always the hardest for me to tease out, due to what I see, the massive psychological components with it. You know, you have somebody who, yeah, I think every guy's been where you're with a new hot chick for the first time and you get so in your head about it that, you know, you're basically, your penis is numb. You've got neuropathy, you know, you're like slapping it in the bathroom trying to wake it up because you're so nervous that you're not going to be able to perform for this chick that you fantasized about for months, you know? And so I try to, you know, work that out with a guy, you know, is this actual organic, you know, or is this just psychological here? And so it's really important to try to tease that out. And then the other thing I think we touched on a little bit in the last podcast was teasing out the desire or libido as a maturing adult with other responsibilities. You know, Josh and I had this conversation the other day where Josh is like, yeah, weekends are kind of like my wife and my time to do things, because throughout the week, we're just so busy with work and the dogs and bills and, you know, everything that sex is kind of way down on the importance list. And then weekends, when everything is taken care of, you know, we can relax and let ourselves go. And I think a lot of guys have that. I think usually around 30 on, when your goals come more, you know, career-based and family-based, like the drive to reproduce is no longer as strong as it once was before you had the children and the career and everything, you know? So what I'll tell guys is I kind of try to play out a scene like, okay, let's say that kids are at daycare, everyone's taken care of, all bills are paid, you got a massive bonus, you and your wife are on vacation, tropical, it's beautiful, she's in lingerie and asking for it. If you don't want it then, okay, there's an issue. But if it's just because at the end of a 12-hour day, after coming home playing with the kids and then going back to work for a few hours before you go to bed, that you're tired and your wife wants it, that's probably not low libido, you know?
Yeah.
100%. That's completely true. I often say that the best fix for low libido is a holiday, because it's stress induced. And I think that it's, and I find sometimes it can be, I don't know, surprising that and I don't mean this disrespectfully to people, but I find it sometimes that it can be surprising that people don't understand this. So I think it's really important to explain it in a way that's very non-judgmental and just very clear. is it like if you've got like a newborn, or like if you've got a new job, or you're getting divorced, or you're going through a period of stress in your life, it's okay not to want to jerk off anytime you got a spare moment. Like you probably shouldn't. Like
Yes.
it's like I've spoken to some guys before, and they're like, "Oh, my libido's really low." I'm like, "Dude, you're getting divorced. Like if you had a high libido now, you'd probably be on some kind of antisocial diagnostic spectrum. Like you're not supposed to. Like that's good. It's good that you don't have a libido now. Like you've got other important shit going on that's healthy. So yeah, it's when you're 16, like I mean, there's surges of everything else going on. You just found out how to use this exciting new toy. Like I mean, it's and the most stressful thing you've got going on is math homework. Like I mean, it's a completely different environment. But I understand that raging teenage libido is always going to be people's reference point, and I get that, and I think that there can be a good middle ground between that. But going to the psychological erectile dysfunction, I think that's a really good point. Because what I often tell guys is that like having erectile dysfunction in a relationship with a woman who you're relaxed by and that you love and that who cares about you and you're attracted to, versus sleeping with random women off Tinder that you don't know. I mean, maybe it's good that you're not getting an erection in those situations. Maybe your body is telling you something. Maybe there's a whole bunch of red flags that he's seen that you haven't. But that first time of vulnerability before intimacy, especially depending on how your self-esteem is and if you had issues in the past, not being able to perform in a situation like that due to anxiety, like that's probably happened to everyone at least once. And if guys say, "Oh, it's never happened to me," okay, you're the exception to the rule. It's probably happened to everyone else at least once.
Right.
That's okay. That's where you need to learn about breathing, or that's when you need to slow the intimacy down and get to know each other first. Go to church. But it's like those kind of things. It's like I understand, because those situations are stressful. They can be humiliating. If that's never happened to you before, it can be especially if you really like the girl, it can be the most anxiety-producing thing, and it can lead to all kinds of other stuff. But that's very. But the thing that I will add in that is the caveat, because I like that this podcast is probably going to confuse people more than answer questions. But there's the other side to this that I think is important, is that when you've got high testosterone versus when you don't, the thing that I can attest to as someone who had low testosterone up until I was 25, is that I was still very attracted to women for that first, the formative years of my adult life. Very attracted. But what I didn't have was that feeling of lust, that feeling of animalistically like, and I feel like that is what overrides the performance anxiety. I feel like that feeling of lust biologically and physiologically counteracts that stress response to the point where you're like, "Oh, fuck yeah, I'm worried I'm not going to perform well. I'm worried about this. I'm worried about that. But fuck it." Like that thing, that's what prevents the other guys, I feel, the high testosterone guys, from getting as much performance anxiety. So I feel like that component of like physical, like lustful desire, like for the physical female form, especially if it's someone who you genuinely love and care about as well, that's very strong. And I think that's activated by testosterone. So I think you're more prone to getting that performance. I think anyone can get that, but I think the lower your testosterone level, the more prone you are to getting that in those encounters.
Interesting. Yeah, for me, like even when I had insanely high levels of androgens and I was almost like at a sexual deviant point, it was weird because intimacy was always so much more important to me than just lust. Like I had to, even if it was a random hookup, I'd been with a lot of women, not bragging or anything, but I would have to somehow tell myself like I really care about this person and fixate on things that I, like really liked in her. And then eventually I realized like, this is just stupid. I just need to find one person who I actually really love, instead of tricking myself into getting into this. But yeah, I think the psychological thing and working with a mate, the first thing I usually tell guys is, if you're not with somebody that you're comfortable enough to talk about this thing with, and, let's, step back a little bit and re-examine that first, re-examine your relationship. Like you said, should you even be sleeping with this person in the first place? And the thing that's more powerful than anything is just being open and having a partner in that person. hey, I'm a little nervous right now. You're really fucking hot. It's getting in my head. Can we slow down for a sec? Maybe touch it this way. I like, when that kind of thing happens. And, when that you have that vulnerability with that person and they're accepting and they understand, it's huge, and that's beautiful. And that's usually when things will be good and you stop thinking about it. So that's the first step that I tell guys who are listening. Just try to make a connection with the other person and be open and work through it. And usually just that one experience, you feel comfortable moving forward,
Yeah, this is such a tricky thing for guys because, like, one, I've been there, and two, like, I've spoken to a lot of guys about this, and I think it's such an interesting conversation because the other part is that guys are worried that if they do speak that out, that the girl's going to lose respect for them because they're going to be like, oh, well, like, and I'm like, I get that. Like, if you read like the Roller to Mastery stuff, the red pill stuff, or the hypergamy stuff, like, that's all stuff that's like drilled into you in terms of not wanting to show weakness. And I get that. But at the same time, what Adam said, like, actually just bringing that up and almost like having them, like, flagging it with them so that they give you almost permission if you fuck up and that you're not worried about it, that will often resolve the problem.
Right.
And I really believe, and I might not have said this a few years ago, but now as someone who's, I've dated, had different experiences, good and bad, dating women. And I stand by that the right kind of woman who you'd want to marry wouldn't leave you or think of less of you over something like that. Certain kind of girls they'll lose respect to you, but they're probably not the kind of girl that you want to marry if that's what's going on. So I get that it's like a vulnerability thing, but I think that, like, if you can just like flag with them and be like, hey, there's a chance this might happen. It's just because I'm nervous and I find you super attractive. And if it does, just, let's just like kiss and cuddle for a bit and keep going, and then it's good. And if they respond well to that, you're going to be sweet. You're going to be fine. And I tell guys, if you're in this situation, like, you need a winning streak. And once you have a winning streak, then it's gone and you're good. You need to get on a winning streak. And I think 5 to 20 milligrams of tadalafil, that's not going to overcome the performance anxiety because that's a cortisol, adrenaline, stress response thing. But if you feel your erection more engorged than it's ever been before, like you feel yourself swinging at like 110, 120%, that confidence is going to override the other stuff. And that's 100%. Going to help. And that's what I like to use as medications for. Insurance policy. I think it's also great because you're going to get more natural erections without worrying about it. And I think that can inspire intimacy when they're around. I think that's really therapeutic and really helpful for the situation. And then if worse, like, people in this situation need to learn how to meditate, you need to learn how to breathe, control your stress response. And then if you're really in a situation like that, don't take something like Valium or Xanax. Look at like a natural calming supplement that's not anti-androgenic. Theanine, a bit of CBD, a bit of phosphatidylserine. I've got lectures on all of those on YouTube. Something like that to just calm the nerves and take an edge off. That with a bit of tadalafil and a bit of a conversation, and like you'll be totally in the zone.
It's funny, you and I have never talked about this, but I give the exact same advice almost, it's funny because I think experience just, you see it happen and work, and we've had our own personal experiences and know it works. Back to kind of like the whole red pill thing and thinking that a woman will lose respect for you. I personally don't think that's likely true due to the fact that I think most people are highly self-important and always think about their self. And I think what will happen more often than not with a woman is if you're limp, they're going to think it's their fault, not yours. They're going to think, this guy thinks I'm ugly, So they're probably more thinking about what they did to you. And it's also nice to tell them, hey, I'm really attracted to you. I'm so attracted that I'm getting nervous and a little bit in my head, and that's going to probably make them be more attracted to you too, and realize, oh, he thinks I'm really hot, because everybody cares about themselves. And then, to your point of using the tadalafil, it's exactly what I'll tell guys. Like, let's use it the first time with the girl. Like, after it's already been hard and you've got comfortable and you can please her, because I think most guys really care about that too. Like, am I pleasing? Or they should, I hope. After you have that one victory, usually downstream from that, you never, go again. That's why, like, hooking up with an ex, even though it's been years, usually it'll be really great sex because you guys are comfortable. You've had millions of victories with her. It's really easy to get that hard again when you're with her. It's not new and novel and scary. She's seen you, she's seen your weird mole that you got on your ball. You're not afraid of that.
Okay, now I know that you've got a weird mole on your ball.
I actually don't.
I was going to say, was that just a...
Yeah. Where did that come from? Yeah. No, it's 100% it. Like there's this like I don't know. I'm maybe I'm old fashioned and conservative or born in the wrong era or something. But like I think that the bond between a man and a woman sexually is very sacred. I think that the act of sexual intercourse is it's a very intimate experience, and it's a very I think it's a very powerful experience, and I think it's something that people need to take really seriously. And I think that when it's treated like that, I think there's less erectile dysfunction, because if it comes later in the bond, I think people are going to be more comfortable. But at the same time, the later it comes in the relationship, the more pressure or expectation there is, because now you actually care about the girl. So it can go both ways. But
Right.
when I look at it in terms of what performance anxiety is, it's a stress response. Blood is getting diverted away from the extremities. What makes you less stressed in situations like this? Feelings of familiarity. So the more comfortable you are around the person, the less likely it's going to happen. And I think that's taking that bond seriously and breathing and slowing down and really, and it sounds lame, but it's totally important. Like really focusing on your connection with the person that you're with. Um, that is advice that can often really help people. And I think having the tadalafil and having something to calm the nerves physically and consciously going in with like, hey, I've had a conversation and everything's cool. I think that that's a way that you can really open up a really good intimate connection, because I think that should be the goal of sexual intercourse, unless the goal is to make child. And I think that that's something which having a conversation like that is the first thing that can open up that door. And I think that the converse to what you said is completely right, in terms of people care way more about themselves than anyone else. And I think that, and I think that a lot of the time, the things that people are worried about happening often isn't actually the thing that's going to be a problem. And I think that, from my own experience, having conversations like that when I was younger, when I had that issue, it was always very well received, and it always fixed the problem straight away.
Yeah,
for sure.
Could we, just because I feel like it's kind of in line with it, maybe touch on the porn subject with that, especially with younger guys, and like what that kind of does, or with the psychological ED, how much that attributes to it, whether that's a overactive dopamine response, or maybe I feel like sometimes it's even giving guys a false idea of like how their sex drive should be, or if they should perform that, how they see it in porn every single time. I've always felt like that's an idea that's just not true, right?
Yeah, the most romantic way to have sex is just to absolutely fucking jackhammer the chick for like 30 minutes.
And every time you touch her, she's gonna have like an orgasmic response.
Exactly.
Yeah.
Yes.
Yeah. And it's, I mean, it's okay. So I think that there are some interesting points that get discussed around this. And I mean, my opinions are my opinions only, and I'm sure I would respectfully disagree with all sides of the coin on this. I think that the dopamine down regulation stuff from porn is overstated. I think that it's often compared to the effects of things like amphetamine. But if you compare something like, methylphenidate and amphetamine, for example, we're talking the difference between a 10 and 100-fold increase in dopamine in the prefrontal cortex. So, like, where does porn fall on that spectrum? I think that I just don't think that it is as strong as people are making it out to be. I think it is a factor, absolutely. But when it comes to things like this porn addiction idea, I said it at the end of my Silverback Summit, and I was very blunt about it, and I got a very good response from it. So I think it went down well. If you're sitting at home compulsively jerking off all day to the point that it's getting in your way of your responsibilities as an adult, dude, like you need to look in the mirror. Like, what the fuck? Like that? No, it's not okay. Like, just that's weird. I don't think that it should really get to that point, and I don't think that if it does, it's porn's fault. I think that that's just a lack of impulse control. Because there are plenty of people who have very healthy relationships with porn, if there is such a thing, that they're able to function normally and just do it at night before they go to bed if that's what they want to do. So I think like I haven't seen any compelling science to show that dopamine. I mean, it definitely increases dopamine. It's highly dopaminergic. The brain does have a lot of issues distinguishing what's happening on the screen from what's happening in reality. So if you've got 8 different tabs open with all the different things you're into, I mean, your brain kind of thinks that you're having an orgy. But what you're missing is all the pheromonal responses, all the physical touch responses, all the stuff that comes from being in someone else's vibrational energy field in terms of the pair bonding and everything that comes with that. So I think that what happens, I think the dopamine down regulation is a very myopic way of looking at it. I think that it's a factor, sure, but I think it's more that like you become accustomed to the nice things. It's like if you fly business class all the time and then you fly economy, it's awful. It's like if you're only jerking off to like 10s and 11s and you're not an attractive guy and you haven't looked after yourself, and then the only girls who'll sleep with you are very unattractive women, it's like, of course you're going to get erectile dysfunction. Like you've become used to such a high caliber that I think can often produce unrealistic expectations for people. So I think that one of the problems around porn is it makes guys too hypervisual and they're not focused in on everything else around the moment. And I think I think the visual aspect of sexuality is only a small amount of what derives pleasure. So I think if you lose connection with the other ones, I think visually it can be underwhelming and that can cause not enough stimulation to continue. But I think it's an overstimulation thing, but I don't think it's just a dopaminergic thing. And I think that I think it is a problem, but I don't think the pornography itself is a problem. I think it's just people's choice to. I mean, you can just turn the computer. Like, if your biggest problem can be solved by putting your dick away and going outside, preferably in that order. Like, you don't have a problem. Like, it's just like you just don't. Like, it's sorry, but like, I don't know guys struggle with this, but it's like just go. If you have responsibilities and things in your life that supersede that, then you can still jerk off in the evening if that's what you want to do and you're still productive. But I think to have the best quality sexual experiences in life, it wouldn't involve frequently looking at porn. And I think that there's the whole moral thing and the ethical thing around it as well, and each to their own and all that kind of stuff. But I think people can jerk off to internet porn in the evening and not ruin their lives. And I think people can jerk off to internet porn all day, and apparently they can ruin their lives. But I think the best thing that you can do if you want to focus on the quality of your intimacy, I mean, even Sterling Cooper, I mean, he's an ex-porn star. He's an Australian guy. He talks about it all the time. I mean, he was at the top of the porn game, and he's like, guys shouldn't watch porn. So it's like, it's a choice. But I think if you are going to use it infrequently. And if it is getting to the point where you're not like genuinely attracted to like if you enjoy jerking off to porn more than you enjoy having sex with your partner, then you either have a problem with the porn or you have a problem with the partner.
Yeah. I think like everything, it's nuanced, and there's, a wide range of what can be normal and okay and deviant and lead to issues. I think for myself personally, porn can be something that I don't know if it's, through the dopaminergic pathways or not, but it can certainly be almost desensitizing. I mean, just like anything, right? Like no matter what, if I had an orgasm right now, my drive to go have sex later is going to, whether it was through porn or vaginal sex, whatever, my drive to have sex later is going to be diminished. And so if a guy is, while the wife is gone at work, rubbing one out on porn, when she gets home, he's not going to be as interested probably, because I think we do have a pool of desire each day. A lot of guys, when we're younger, maybe not, but as you age, you have kind of an orgasmic cap for most guys. So if you kind of wasted that on porn, of course your libido with a real person will go down. And then also the type of porn that you're consuming, are you consuming this extremely, graphic, like you said, just unrealistic thing, or, orgies and craziness going on and stuff that is not realistic that you'll never experience. And are you, obviously seeing something at 110%. So when you see real life, it doesn't work for you. And then the other would be the mode, like the actual mechanical orgasm that you're having. If you're just doing a dry rub every single day, and that's what you've accustomed your penis to, having an orgasm, a vagina may not feel as good. I mean, I think the first time I ever had sex, I was surprised that it wasn't that great. I thought it was going to be like the second I went in, it was just going to explode. However, guys, I'm like, this is actually taking a little while because, I've just been a little kid with, no lotion my whole life, and it was different, And so I think that the mechanical actual thing comes into play too. Are you somebody who is just dry rubbing it all the time, and that's how you've taught yourself to orgasm, and now a vagina doesn't work as well?
Yeah, I think that's definitely a factor. And I think the guys need to just take a step back and look at what's going on. And I think that I covered a lot of this rationale of thinking in my Silverback lecture, but I was like, most guys know, like if you just take a deep breath and close your eyes, you can work out what the cause of your sexual dysfunction is. I think another factor that doesn't get talked about anywhere near enough is when guys, and I didn't realize we were just going to have a sex conversation, but it's
I know.
I was just thinking the same thing.
I think a really good point. Yeah. Cool. We're all thinking it. I think one really good point that doesn't get spoken enough about a lot is that guys focus on either they come too slow or they come too fast. or how much they want to have sex. They don't focus on their actual sexual performance. And sexual performance for a man, if you're doing it right, as far as I'm aware, is quite an athletic endeavor. I was in a touring band for about 5 years, and I saw, unfortunately, from sharing rooms with disgusting, 10, 12 groups of band dudes and the disgusting women they would associate with, I unfortunately walked in on my fair share of people doing things I wish I hadn't seen. And the thing that I was always so surprised by is, I didn't know that's you're not supposed to do it like that. Like, I was just, dudes were just flopping their entire body mass on the chick and just humping them like a fucking seal. There was no propping of the bridge. And I was like, I was like, okay, well, if these guys can get laid, I'm a fucking stud. Like, I was like, oh, the bar is low. But I think one thing that guys should be looking at when they're looking at their sexual performance as a whole is, and Sterling Cooper talks about this really well. I don't know what specific exercises he references, but strengthening your posterior chain is going to do more for your sexual performance than doing some Kegels when you're driving or doing a bit of edging when you're jerking off. Like, if you really want to be working on your sexual performance and everything around that, you should be working on things like how long can you hold a plank for, like barbell hip thrusts, like high volume barbell hip thrusts or with weight, your like deadlifting, Romanian deadlifting, all of these movements that are going to actually support your ability to have sex and not fatigue and not get stressed. Because I know that one thing that's happened to a few guys who I've spoken to is because they're out of shape, when they're having sex and they're, on top in missionary, they will physically get a stress response because they're exerting themselves so much. And then that's why they'll get performance anxiety. They'll lose their erection. They just hadn't thought about it that way. I'm like, do you get really gassed when you lose your erection? They're like, yeah, I'm always super fatigued. And then I just get stressed out and anxious. And it's like, that's a factor as well. So I think that there are so many different angles that guys can look at this from. And if they're in a situation where they're like, I'm not confident sexually and I've got this new girl I like, being like, okay, I'm going to, do more posterior chain work in my workout. I'm going to work up to holding a bridge for 2 minutes. And then I'm going to, work on things like improving the mobility of this area. So like arch to grass split squats, Cossack squats, those kind of muscle movements, and then get some tadalafil and maybe some ashwagandha, CBD, phosphatidylserine, something to calm down. And then if they just approach, kind of like we talked about before, approaching all the areas rather than just maxing out on one, I think they could set themselves up for a completely different sexual experience within a few days.
Exactly. Well, that may conclude our talk on sex. That was a nice little aside, but so that was one symptom to look at when we're looking at testosterone. I think we did a pretty deep dive, and I think that also speaks to, again, the nuances of all of this. And if you're going to a clinic who is just putting you on TRT right away because you said, I couldn't get it up with this girl last night, you're at the wrong place, because we just talked for a half hour about all of the, we just touched it on all of the things that could be impacting that erection that one time. So again, this takes a lot of looking at the whole picture and putting it all together, the lab work and the symptoms and everything. But let's say that a appropriate provider has done that and given it a full, thorough examination and concluded that you are in need of testosterone at some point. What are the options for the replacement therapy? There's things like creams and pellets and injections. What do you think is the best mode of administration? And are there differences? Is there one superior than another?
I think assuming that price is going to be the same, because there are countries, like I know in the UK, for example, Testosterone's super cheap. Your clinic might so assuming that pricing is all roughly the same, because if something is a tenth of the cost of something else, then it may be the superior option. But in general,
price and availability,
price and availability all the same. So I think that testosterone, cypionate, and enanthate is going to be the best choice. It's what I wrote in my TRT 101 book a year ago, and I stand by that. The reason for that is, and a lot of the stuff that I talk about is down to numbers in terms of when I see 20 to 40 people a week over the space of the last few years, this has just been the shit that's worked, which is why I do that. And I find that if I gave 100 guys, either cypionate or enanthate, and I just say, look, they're Coke and Pepsi. You could swap them interchangeably if you want to. Yeah. So they're the same thing. So I find that if you put 100 guys on either one of those, 99 of them will respond well. I have had a couple of guys who just, their FSH and LH levels just didn't move. They didn't drop. It just didn't work. They were doing everything right. Literally had the 2 guys in 3 years. I've had that. And we checked it wasn't a bunk product, everything. They just didn't respond to that. They responded to cream. But 99.9% of guys will respond to that. You might get a hyper response, you might get a low response, but you'll fall at about 50 to 60% of guys will fall. I don't know what the conversion for the US units is, but on about 150 milligrams a week, most guys, the majority, will get a total testosterone of about 30 to 35 picomole per liter, or nanomole per liter. The Australian units, the reference range of about 8 to 25 to 30. Whereas cream, I would argue, delivers a better subjective response for the guys who respond well to it. But if I put 100 guys on cream, I might get 60 guys respond well to it and 40 guys respond less than 50%. So it's not going to be viable. So for the sake of, when it comes to TRT, I'm a big believer in getting, like, I always say to people, and I know it's an oversimplified question, I go, how do you feel scale of 1 to 10 right now? And I say the goal is to get you to a 7 or an 8 as fast as possible. And then we can start to tweak with shit to get you to the 8 or 9. But if you're at a 2, the priority is not to get you to a 10, it's to get you to a 7 or an 8. And that's easy. And then we can start to look at the other variables that might close the gap. But that's why I prefer to start with injections, unless someone is particularly adverse to injections, in which case cream is an option. I think cream is great, but I think logistically, cream is not forgiving enough. And I think the transference and compliance issues for the majority of people are.
I think you broke up there for a sec.
Oh, really? Am I back?
Oh, yeah. I don't know. That's
You're
all right.
good.
Did you hear that, John? Okay. Yeah. We're good.
Just like for a quick second.
Yeah, I just got to make sure everything's good. So yeah, when it comes to injections, then too, is there a superior way to inject? You know, if you look in endocrinology textbooks, it may tell you a dose once every 2 weeks. Is there a more superior way of doing so? I think you see where I'm leading you to.
Once every 2 weeks is good. That's fine. Totally.
Yeah.
No, it's first thing, you stick the pointy end in. But look, it's the half-life is not agreed on. I've seen some studies say the half-life is 3.8 days. I've seen some studies say the half-life is 14 days. That's a big difference.
Yes.
And I think the depth of the injection is a factor in release. We know that deeper injections, and Victor Black does this in one of his videos, but I couldn't for the life of me remember which one, but he shows a very good chart where he shows that different muscles uptake faster and different depths into the muscle uptake at a different speed. So I hypothesize that that's why these studies have different pharmacodynamic responses, because they wouldn't have done the same injection. That to me makes sense. But I think that the half-life and the active effective life, the duration of action, is very different. Caffeine doesn't have the same acute effective life as the half-life. Caffeine doesn't buzz you steadily for 4 hours and then taper off steadily for 4 hours. It doesn't work like that. We all know that. So I think assuming that testosterone is going to do the same thing is naive. It doesn't make any sense. And I think that when you speak to people subjectively, I think the 3.8 day half-life is more what you see in practice, because I found about every 3.5 days is the minimal amount that and there are guys who can get away with every 5 days, every 7 days. I haven't met anyone who can get away with it every 2 weeks, but I've got plenty of guys who do it every 10 days because they just won't do it more often. And I'm like, you feel good all 10 days? They're like, yeah, cool.
Right.
But I think twice a week is the point where it's going to be, for the vast majority, let's say greater than 75%. This is going to be the minimal amount that you're going to have to inject. And I think that you're going to spend less time injecting than you spend brushing your teeth per week. And I think that 2 tiny little insulin syringes into the delt per week is cruisy as, considering the benefits that you get.
100%. Yeah. So for those listening, what we're kind of getting at is that if you go to normal medicine standards, they'll tell you that you can inject once every 2 weeks. And what we see occur is levels will spike and a guy will feel really good for a day or two and then usually crash. And then I just saw this the other day. A guy came in, he was given an injection once every 2 weeks. By the time that he saw me, when he got that lab work done in his trough, right before he would have injected again, his LH-FSH had already come back online. These should be suppressed.
Really?
Yeah. His testosterone was around like 90. He felt awful. And he was telling me that his injection day is Friday. And on Friday, Saturday, Sunday, he'll feel really good. But come Monday, he needs to get these morning workouts in. Otherwise, he can't work. Come Monday morning, he has no energy to get up. And then that just snowballs throughout the rest of the week. He's tireder and tireder every single day for 2 weeks. That's awful. So what, people are like, Dave and myself have kind of realized if we do more frequent, smaller injections, which more mimic how the body would naturally produce testosterone, which would normally be daily, we can get a level that gets up to the optimal range and ideally kind of hovers in that optimal range rather than these peaks and valleys. What that also translates to, what we see is less estrogenic side effects, because when you spike testosterone really high, you get a large suppression of SHBG. You get a lot of free androgens floating around, which can be aromatized into estrogen. And that will, oftentimes relate in estrogenic side effects. And then guys will just be put on an AI. And then you get a host of other issues from that, where we can almost offset a lot of that stuff just by giving, these more frequent injections and keeping guys steady and keeping a steady ratio of estrogen and testosterone together, So there's a lot of benefit to doing the more frequent, smaller injections. It's also a lot easier. Like you said, you're going to spend almost no time doing so. I tell guys like the total weekly volume is already small. Now you're going to divide that by 2 or 3. Like you're basically injecting drops into yourself. It's so easy.
Yeah, I tell guys, like a teaspoon's 5 mil. You're injecting 0.3 of a mil. Like a ton. Yeah. So yeah, and I think that in a perfect world, I think daily intramuscular testosterone cypionate or enanthate injections are the best. But I don't think people are going to do that, because you're just not going to stab yourself in the muscle every day. There's a big difference between stabbing yourself 2 days a week versus 7. And the novelty wears off pretty quickly. But I think from an idealistic standpoint, that's the best. I think daily administration is the best from an idealistic standpoint. I think if we go back to this fortnightly injection nonsense, what that does, because the testosterone and then its metabolites, DHT and estrogen, etc., they all move in different patterns. So all of a sudden now you've got this female-looking hormone cycle over the month where your hormones are doing this dance, like they have progesterone and estrogen do this dance over a month. You're not meant to have that. You're meant to have a daily flatline. You're meant to be steady. Now, yes, testosterone does go up and down, and I would argue that the most bioidentical TRT methodology is either a once morning application of cream or a daily test prop injection. That's going to give you the most. It's less forgiving than using the enanthate and the cypionate, but that's what's going to give you what mimics the daily rhythm the most. And I have had my first line of, and I guess I don't talk about it as much anymore because I talk about more other topics because I've just hammered it to death so much. But if you're in a situation where, and there's so many exceptions to the rule, this is not a rule, this is a template. The more off track you are, the more often you should inject. Like if you're lean and healthy and you've been lean and healthy for a while, you're probably going to get away with twice a week injections because your body is less inflamed. And so you're going to be able to deal with having a bit of a peak and having a bit of a drop, and you're not going to know about it. But if you're, insulin resistant and you're hypothyroid and you're overweight and you've been drinking and you're not looking after yourself well, you would benefit from injecting maybe 3 times a week or maybe even more, because you're giving yourself more stability, which is going to cause less problems because you're going to be able to tolerate it better. And people might hear that and go, that doesn't make any sense. But in practice, the guys who I've had to go, hey, I want you to do daily injections, 29 gauge syringe into the delt for 6 months while you drop 10 kilos.
It actually, I think it makes sense from a physiologic standpoint if you think of SHBG, and if they're insulin resistant and they have high levels of fasting insulin, their SHBG is going to be crushed. And so if you inject more frequently, you'll actually help them to bring up that SHBG and carry around more testosterone and not have this, like we said, overwhelming free testosterone that causes sympathetic overdrive or the crank feeling that you talked about. So it actually does make sense from a physiologic standpoint as well. Yeah,
100%. And I also think that for the guys who are doing less well, like let's say that the bigger guys or the guys who haven't looked up, the guys who are further off track than they would like to be, sometimes I say, look, you should look at cream, because cream metabolizes differently into DHT and estrogen. And I think that that's a way that you can push that a ratio or a profile of the three of a more healthy man into an unhealthy man. And so if I've got someone who's on cream, and I've done this many times, like guys who are like morbidly obese, they're losing weight, they've got everything dialed in, but they're like, I need help in this department. And it's like, yeah, we need to, this would be a good idea. I find that I wouldn't give an obese guy the same levels of testosterone as a healthy guy because it doesn't make any sense. But using cream to boost his levels up to kind of kickstart that, I find that that's better tolerated just from a clinical setting, produces less side effects as well. So I think that I think the healthier you are, the more lax you can be with your protocol. And I think that copying, if you're getting side effects and you're not doing well, sometimes just going, hey, 6 months of daily injections while I sort my shit out, cool. Then you can drop back and then you can go 3 times a week, twice a week. So
And
Could you
again,
get into that?
recurring theme.
Sorry,
I
Adam.
was going to say,
I was gonna.
recurring theme is that we have these nuances. There's so many things that you need to really evaluate. And I think that something that I get really kind of upset about is the dogmatic approach on either side of the things. I brought up the normal medical one of one injection every 2 weeks, sometimes even more, which is just absurd. But there's also this new wave of these TRT clinics that say, oh, we're not cookie cutter. We do 3 injections a week, but that's all they'll do. And they think that anything less is just absurd. And I'm like, you're still cookie cutter. You're just a different cookie. It's like you have this plan. And so, like you said, you have guys who sometimes they do every 10 and they're functioning just fine. So everybody is different. And if you don't have a practitioner that is dialing in specifically you need to find somebody else.
100%. Josh, what did you want to add in?
Oh, I was just going to add, you mentioned the cream kind of giving, I guess, a different maybe conversion ratio to DHT and estrogen. Am I correct in that you're getting more of a direct or higher conversion into DHT and estrogen with the cream, or is it vice versa? I was just kind of curious your thoughts on that or why you mentioned it.
Yeah. I'm going to preface this and give credit to my friend Jordan Grant, because he would turn around and say, well, serum levels of paracrine hormones are not relevant. And I agree, they're not totally relevant, but they're kind of relevant. They serve a piece of the puzzle. And I think the interesting observation here is if you put a guy on a comparable dose of injections versus transscrotal, high quality cream, let's say whatever dose is required for them to produce the same total testosterone, the DHT levels in the serum will be orders of magnitude higher in the cream guy. Like I have plenty of guys who've got optimal testosterone levels, and again, serum DHT is it's a proxy. It's not that accurate, but I do find that guys who are overweight have lower DHT levels and guys who are leaner have higher DHT levels. And we just see that in the way that these people, that their external characteristics in terms of physically and personality wise. I mean, you look at that and you go, yep, that makes sense. But I find that the DHT application of cream, when you actually measure DHT, it can often be 2 to 3 or 4 times higher than the range. Now, it's happening at a skin level, so that doesn't represent what's happening at, what's happening in the blood doesn't represent necessarily what's happening in the cell. But I think it's pretty well agreed upon that there is more DHT conversion from the testosterone when it is applied scrotally to the testicles. And then as a result, DHT has antagonistic, balancing, counteractive effect on all estrogens, not only just on aromatase, but on the way that the estrogen receptor functions as well. So it's kind of like the balance after you put it in the body changes a little bit in terms of what the outcome is. And I think that what causes some of the side effects of the higher testosterone levels in the obese guys can often not be dispelled, but be mitigated a little bit by going for the cream option. But not everyone responds well to cream. So then you've got that issue to play with.
Yeah, absolutely. Thank you.
So you brought up estrogen and everything, and that's something that a lot of guys will be concerned with too. Should guys be concerned with their estradiol levels? Is there anything they should do to mitigate it? When does that become an issue, and what to do about it?
Yeah, again, the ultimate depends on who you ask question. There's a lot of different camps regarding this, to the point that people become quite hostile to one another over it, which I think is quite strange. It's almost become, I think it's almost become religious, which is weird. At the end of the day, like, I couldn't give a fuck if people want to take an aromatase inhibitor. Like, a whole bunch of people that want to take an anastrozole, it's not going to impact how I sleep at night if you take an anastrozole or not. Personally, in the way that I practice TRT, or the way that I advise my clients to practice their own TRT, is that I don't use aromatase inhibitors because I haven't found them to be necessary. The issue that I have with aromatase inhibitors, and this is there's a whole other side to this. You could counter argue each of these points, but firstly, like, every positive study on testosterone hasn't used an aromatase inhibitor. They haven't inhibited aromatase.
Yeah.
And there are no long-term studies on the use of testosterone and aromatase inhibitors, so it's not evidence-based medicine. But at the same time, there could be a study done on it that proves it to be really great. So I mean, that's it. It hasn't been proven to be bad, but it also hasn't been proven to be good. So I put pharmaceuticals in guilty until proven innocent. So that's why I take that outcome from that. But people could argue the other side. That's cool. I also find that a lot of the time, and Keith Nichols says this really well on Jay Campbell's first roundtable back, talking about the studies that show the harms of estrogen in men, is that these are baseline, his words, they're baseline studies, i.e. they're not, we put a bunch of guys on TRT and these guys got high estrogen. It's these are guys with high estrogen level at baseline, and they've got a bunch of problems. But we know that that higher estrogen level with the lower testosterone is because the bodies, when they're in a sick, overweight, inflamed state, is they will drive up the production of aromatase because estrogen is anti-inflammatory. So the idea that, like, I think that a lot of the time the estrogen is the bystander and it's not actually mechanistically causing the problem. I think if anything, it's like cortisol. It's the anti-inflammatory that the body's releasing in response to the problem. That's just from what I've deduced. So at the end of the day, like I've spoken to a lot of guys. I've taken a lot of guys off aromatase inhibitors and they've gotten better. And I've also had a lot of guys who I'm not insulting them for doing this. I respect their process. Is that they wanted to take the AI. I told them it was going to be a bad idea. They said, I'm going to do it anyway. And I said, good, that's going to be how you're going to learn. And then they all came back and they said, yep, cause problems with shit, not taking it. But yeah, good.
Yeah.
I think a lot of guys want to take AIs, and I understand why, because they're looking at themselves, they're experiencing life through their lens as them, and they know that they're not as masculine as they would like to be. So they're like, I'm going to take the pill that's going to block the feminizing part of me, and that's going to solve the problem. I get it. Like, it makes sense, but it doesn't work. But like, I get the mentality. I really understand why they're looking for that. And I think what they're actually looking for is, one, a lot of them need more testosterone. That's a factor. And they need a better protocol. They need a higher, more frequent dose. I think some guys are also loaded with xenoestrogens and biological estrogens, which aren't impacted by aromatase. And I think those guys benefit from liver support supplements to try to clear that shit out. I don't think it's a perfect fix, and it's an imperfect science. I asked Eric Serrano about it, and he recommended high doses of glycine. I think that's a good approach as well. There's a really good supplement for guys who are, and I'm not going to mention my discount code for this because then it sounds like I'm shilling shit, so I'm going to mention it without the discount code. There's a brand in Australia called Level Up Health, LVL Up Health. I helped them, I gave them some input on the liver complex formula they've got. I think that's the best formula on the market for potentially working on the xenoestrogen side of things. It's just a complex of everything. Otherwise, if guys want a cheap option, Now Foods Liver Refresh on iHerb or Amazon, almost as good. Great way to look at it. So that's the kind of thing I look for that. But then I also look for, well, if someone's got an estrogenic problem, why would their body be making too much aromatase? Okay, because they've got an issue. So what's the issue? And I find, like, firstly, T3 is one of the main things that regulates aromatase in the body. So if they're hypothyroid, they're going to make more aromatase. So you check them for hypothyroidism. That's a big one. Another one is insulin resistance. That's going to upregulate aromatase. So a lot of the time, people don't want anastrozole; they want metformin. If you look at a study on metformin, it reduces aromatase in diabetics. So that's actually working on the root cause as a band-aid while they fix the root problem. So that can be an issue. Non-alcoholic fatty liver disease impacts stage 2 liver metabolism. Gilbert syndrome. People don't treat Gilbert syndrome. They say it's benign, but then you look at why is the bilirubin high? Because they're not metabolizing stage 2 properly. So liver support can help with Gilbert syndrome. That can be because if you look at Gilbert syndrome, it does impact your body's ability to metabolize estrogens. It's just not in the clear statements. But if you look into it, it is there. There is some stuff that suggests that. So there's a bunch of nuanced stuff. I also think chronic pain is a factor. I think if you've got, a bulging disc, or you've got a tear, or you've got constant pain, I think that can be a factor that can also drive up prolactin, which will then also drive up aromatase. So it can, a lot of this stuff is going, it's like a mechanic. It's going, okay, we need to pop the hood and find where's that noise coming from? What's the problem? We don't just go turn up the stereo. Oh, it's not making a noise anymore. You're all good. We've got to go in and we've got to find that problem. Because that problem is going to cause a whole bunch of other shit to go wrong as well. This is like your first alarm bell. So don't take the batteries out of the smoke detector, because then when there's a real fire, you're going to be fucked. And that's what I feel like is happening a lot of the time with this AI use, is that guys are going, hey, I've got a problem, something's off. And they're being told, oh, no, everything's fine. But it's like, no, you need a comprehensive assessment. You need a good conversation with someone who's going to listen, who has all the tools in the toolbox that you might not even know that you need. And then you need to have a proper examination and conversation around what's going on.
Absolutely. I think that getting back to how guys are looking at estrogen, if we can fix that and kind of teach them, that estrogen is not a female hormone as much as testosterone is not a male hormone, realizing that women have more testosterone than they do estrogen. So this estrogen isn't even a real female thing. It's just a human hormone. And I look at estrogen as being very powerful. A lot of times I think some guys have issues due to low levels of estrogen, and we need to bring that up. And estrogen can make a guy feel amazing. I think estrogen is neuroprotective. I mean, when you look at what happens to the brain if you crush estrogen and just give them a ton of androgens, it's pretty neurotoxic, you know. And I talk to guys, I'm like, I don't know if you believe in God or if evolution, you know, if you just think that things work perfectly, but it would make sense to me that our body converts testosterone and estrogen probably for a reason. And usually the problems that testosterone cause are fixed or protected via estrogen. You know, we can have cardioprotective benefits, et cetera. Like you said, inflammatory benefits or anti-inflammatory. So it's really cool. Estrogen plays an awesome role. And when you change the way that you think about estrogen, it helps a lot. So when you think this is helping my brain health, my cardiovascular health, it's helping my libido. There's even hypertrophy pathways through estrogen receptors. You know, you stop thinking, oh, I'm feminine because I have elevated estrogen. And another thing too is, like, you know, the use of Clomid or enclomiphene. My theory is why guys don't feel as great on it is because we're blocking the estrogen receptors and not getting the benefits that they otherwise would via, you know, estrogen. Because on paper, you'll see enclomiphene or Clomid raises guys to the upper end of normal, and they should feel great, but they feel no difference, maybe even worse. And then you put that and you give them the same number on testosterone and they feel amazingly, you know? So my personal thought is that it's mediated via that estrogen receptor.
I completely agree. I think that I'm glad that you said this because no one else has agreed with me on this. We know that Clomid makes people feel like shit. Well, not everyone, but it makes a good amount of people feel shit. I'm sure you've heard the same thing, is that if I again, I mean, just hypothetically, if I have 50 guys who use tamoxifen for a PCT and 50 guys who use Clomid for a PCT, there's going to be more guys in the Clomid group who are like, I feel like shit, suicidal, I've got side effects, I've got problems. Why do we, based on what those side effects and problems are, why do we assume that that's from the estrogen agonism side of things? Why do we just assume that, oh, if we get rid of zooclomiphene, then all the problems are going to go away? But it's like, if it's psychologically making you feel shit, it's an antagonist in the brain. It's not an agonist in the brain. So you're not blocking the part that's psychoactive. And given, like, we know what the functions of estrogen are, we know what the functions of blocking it are, and then we look at those side effects, it's going, that's not from estrogen agonism, that's from blocking it. And now you're just isolating the problematic part. But people go, oh, estrogen's bad, so if we take out the pro-estrogenic stuff, it's going to make it better. It's like, no, it's going to be just a different kind of bad. It's just going to be an unbalanced bad. And what you said before about estrogen mediating the effects of testosterone, and whether you believe in God or evolution, it's by design. It's the same thing. It's like, what's one of the best antioxidants for sugar? Vitamin C. What's in fruit? Sugar and vitamin C. You know, that coffee is full of caffeine, which is a stimulant, and it's also got hundreds of other antioxidants that counteract the pro-oxidant effect of the caffeine. Like, and that's why it's one of the reasons. I mean, I'm super biased, but I'm aware of my biases, and I like my biases because I feel like they serve me. I don't like pharmaceuticals. It's like, if we're going to fix optimal male health, I have this idealistic perspective that we should be able to do that with bioidentical hormones and not using pharmaceuticals.
Do you have any, I guess, like, you know, going back to ranges, I know obviously it's not everything as we've been talking about, but for estrogen with guys on T, I heard Vigorous Steve talk about this one of his videos, but just that maybe guys on T, because you've got maybe, you know, higher top end of the reference range level that is always steady state there, you might need a little more estrogen to antagonize that, meaning just a higher serum level in comparison to a natural guy that's going to have those peaks and valleys and might not need as much to kind of mitigate some of the negative side effects of testosterone.
100%, and that it's completely true. That's very, very true. And I have found that in my experience, estrogen falls in the Australian units. The guys on TRT, it's generally got a 2 in front of it. It's 200 and something. And most commonly, this is just what I see on average, it's within striking range of about 250. And I think in the American units, it puts you between a 60 and a 70. And I think that's where Serrano says that he likes to see it. I think that's where, when I optimize someone's testosterone and do the protocol right and they're looking after themselves, they tend to be in the 200s, typically around the 250 mark. Now, there's probably more guys under 250 than over 250, just from what I see. And I've also found that there's a good bunch of guys who still fall within the reference range for estrogen, even with optimal testosterone levels. I've also found some guys who take their estrogen levels up into the 400s, which I think goes up to like 90 or 100 in the US units. But the thing that I have found is that estrogenic symptoms, in quotation marks, don't map with estrogenic serum levels. They don't. I've had guys with, if we're using the US units, I've had guys complain they've got estrogenic problems in the 30s. And then I've got guys who say they have zero estrogenic problems in the 70s with a similar testosterone level. So I think that that's where the estrogen level should be. I've seen healthy guys with it higher. I've seen healthy guys with it lower. I think receptors are a factor. But I think that what we should be doing is putting the testosterone in a fashion that is most optimal in terms of, is the juice worth the squeeze in terms of application methods, in terms of like, the amount of times you have to stab yourself versus how flatline you can get it. And then we should be supporting the body around the testosterone so that it works and metabolizes properly. Because most of the time I find that the people who complain about the estrogenic stuff, they either just haven't been on testosterone long enough I'm just like, dude, just give it a year and it won't be a problem. Just give it a year. It's a lot of the time it's new people, or it's a lot of the time it's people who've they're just overweight, or they've got work to do, or they've just psychologically never had high testosterone levels before. And it's like, it just doesn't feel like it's working properly because it's not working properly yet. Like I've been on for 7 years. And I feel significantly different every year than I did before. It takes time. And I think that if people can have a bit more of an allowance and patience for it to do what it needs to do and measure the progress they're making in terms of how far they've come, not how far they are off their goal, I think they'll feel a lot better about the journey that they're on.
Interesting.
Love that.
So now I guess we've covered when to maybe go on, how to go on. Maybe the last thing in this episode that we'll touch on would be add-ons hormonally too. We'll talk about supplementation, which I would love to get into a whole episode on neurosteroids in the future. But this one, maybe let's just stay within the hormones, because there's clinics now that will start people out on testosterone and say nandrolone. And I guess you can say, yes, nandrolone's a bioidentical hormone, but not to the level that they're putting people on. I personally really dislike nandrolone. I almost never recommend it. From what I've seen you put out, I think you and I have very similar biases on it. And so I would love for you to just help to, I don't know, flourish my bias a little bit,
But it's good for my
The
joints.
same bias.
Yeah.
We probably have the same bias because we both actually sat down and read the same paper. Like if you read the literature on nandrolone, it's look. I feel like when it comes to nandrolone, I think I've said this before, and I'm sure you've seen me say this before. Is that I feel like people are looking for the novelty and excitement of a medical excuse to take an anabolic steroid. I understand that. I've been there. We've all been there. And then what I want people to understand is that nandrolone is the worst of all the anabolic steroids in terms of how it makes you feel. If you imagine testosterone makes me feel like X, nandrolone doesn't make you feel any more like X. It makes you feel like Y. Nandrolone is a progestin, and it doesn't have all the SARM-like properties of tren. I don't think nandrolone is inherently masculinizing from a conscious perspective. I think it's feminizing. I have not had someone to date who's been like, I added a therapeutic dose of nandrolone and I psychologically feel better. Generally, I feel a bit shitty, but my joints feel better. So nandrolone, the problem with nandrolone in terms of the confusion around how it's used is there is one study, and I put the study in very loose quotation marks because I don't know what technically has to be done to define a study, but whatever that is, it must just scrape the bare minimum. I wouldn't call it science, but they took a group. I'm probably getting the numbers roughly off, but the gist is accurate. They took a group of guys with TRT, and then they found all the ones who had joint pain, and they gave them half their TRT dose again in nandrolone. So if you're taking 200 milligrams a week of test, they added, so they didn't subtract any tests, they added 100 milligrams of nandrolone, and then they checked your self-reported pain metrics at 8 to 12 weeks and published the results. That's not a study. They didn't look at any blood. They didn't look at anything. They just went, how's your pain? Oh, it's better. Oh, okay, well, we should all add 50% of nandrolone. No, that's not what that study was saying. So nandrolone was originally available as deca ampules. It was 25 milligram per mil, not 250, 25 milligram per mil, and it was prescribed every 3 to 4 weeks. That does not mean that the prescription dose for nandrolone is 50 milligrams every week with your TRT. That is that is what 6 times higher than the study dose. So if people are going to use nandrolone, the way I recommend doing it is this: is getting yourself some NPP, which your clinic is of course legally going to prescribe for you. We can in Australia, so you legally get yourself some NPP. You want to get NPP because nandrolone propionate is going to get out of your body when you decide that you don't like being on DECA. The worst thing with DECA is taking it for 4 months before you realize that that's what's causing all your problems, and then it's going to take you another 4 months to clear it from your body because it's got a slow ester. So I like to, my dose for nandrolone therapy is 10 to 12 milligrams a week, 10 to 12.5, depending on how it breaks up into the dose, whether it's 200 or 250 milligram per mil. And I typically give it to people once a week I advise the doctor to prescribe it to people on once a week on a Monday. Now, for the NPP trial, I like people to use 1 to 2 milligrams a day for a couple of weeks, because that way, if it gives you side effects, you can discontinue it and you're not going to have them stick around for as long. People say, oh, I'm not going to bother with that. I would say that more people respond badly to DECA than don't. So you would be playing a game of bad odds if you neglected that. It's not just like it's a 1 in 10. It's a badly loaded Russian roulette gun. It's not one that I would play. Yeah. But DECA's the last line for joint pain. It's not the first. That's like saying, oh, I need to cut my grass. I'm going to go get the chainsaw. Or it's like, oh, I'm tired. I'm going to go hit the meth pipe. It's like, it's not the frontline treatment. So the frontline treatment for joint pain is to assess your movement patterns, and to have them assessed by someone who specializes in movement, like a body worker, to see, are you moving properly? Look at your exercise selection. Look at why your joints might hurt. That's number one. Secondly, supplements like 3 to 4 grams of EPA, DHA combined, potentially high bioavailable curcumin, CBD oil, collagen, those things first. And then if that fails and the movement fails, nandrolone. I've got some, like, if you have a mechanical problem in terms of like a post-injury misalignment, nandrolone can be the night and day difference between you being in pain to walk and you going back to squatting under the bar. 10 milligrams a week of nandrolone can do that. But if you've just got joint pain because you never stretch and you squat 3 plates aside, you don't need nandrolone, you need a yoga mat.
Yep. Right. Yeah, the nandrolone for me, my biggest concern, I think, as I age is my brain, and looking at nandrolone's neurotoxicity is crazy.
Oh.
You know, I did a video a few back called Nandrolone Made Me Stupid, where I was talking to Josh about, I literally did this experiment just maybe a month or 2 ago, because everybody's wanting nandrolone for the joints. I'm like, okay, I'm just going to run, because I did a lot of high use nandrolone in my steroid days. I added in 10 or 20 milligrams a week. So a small amount, even more than you're recommending, but a lot less than these pharmacies are recommending, because, or not pharmacies, but clinics. They're usually putting people on 100 milligrams a week on top of their TRT, which is crazy. But I literally felt my verbal acuity started to drop significantly. I kind of felt more brain fog. I didn't feel great at all. I've had friends too that say that it makes them almost feel emotionless and kind of gray. It's just a weird compound. And I think it really does interact with our brain chemistry a lot. And that's why I highly dislike it. And yeah, to your point on like the studies, I've seen one study where it's like guys had joint pains and they were hypogonadal, and then they gave them nandrolone. I'm like, okay, you gave them an androgen and they didn't have as much pain. That's not science. You know, like you said, there's like, we didn't control for any variables. That was the stupidest thing I've ever seen. And then it's just been propagated through gym culture that it's, for the joints, to lubricate them. I'm like, no, I mean, testosterone and the estrogen, as we're getting back to that, is going to do that too. And then when it comes to joints too, a lot of people say like, I have arthritis. Well, no amount, like after you understand what is happening in arthritis, meaning the bones are fusing together to limit motion as a protective mechanism to avoid pain, because the motion hurts. So your body says, let's fuse it so that joint no longer hurts. As soon as that fusion has taken place, there's no amount of any drug out there that can unfuse that bone, lay down cartilage and make a supple joint. It's just not going to occur. So there's a lot of guys that have these mechanistic injuries of like, the joint is not functioning, and they're thinking that they can put like BPC in or nandrolone. And I'm like, no, that's too far gone. Nothing's going to help at this point. And it's easy for clinics to sell things like, oh, you got an achy joint, let me give you some drugs, but that's just not the way it works.
No. And what does work is primarily seeing if there's something movement related that can help. Like, There's a lot of situations where, like, you know what, will help 100 hours of yoga. You're just not going to do it. Of course, there are situations where that won't help, but things like reformer Pilates and yoga and like assisted stretching, I've seen that shit do more for people than anything else, especially in combination. But there are some injuries that don't help. One thing in terms of people being like, okay, if I'm not going to take Nandrolone, what do I take? I'm not selling anything, and I'm not saying this will work, but one of the things that I love, if it is legally available in where you live, is called CBDA, the raw, non-heated version of CBD. It's an NSAID without destroying your stomach. So it's like I say, look, if you take some raw CBD in the morning, which is activating, and then some decarb CBD in the evening, and then you take something like, you know, your glucosamine and MSM and maybe some other, you know, omega-3 fish oil or some like a Now Foods antioxidant complex, you can hit a bunch of buttons that's like taking a little bit of ibuprofen every day that's good for you. It's not going to make the pain go away, but I'm like, well, if you could take 3 or 4 supplements that cost you $50 a month that are good for you, that bring your pain down by 20 or 25%, maybe that means you could do 20 to 25% more rehab and recovery, and then that would lead to a 50% net increase in reduced pain. So that's how I like to look at those things. I often say to people, look, you don't need a medication. You need a combination of a holistic approach of some supplements and some movement and the interplay between the two. And then you need a good body worker and some, but I think people are looking for the shortcut. And I think when the shortcut has a bit of taboo-ness to it, I think that's going to be very exciting for people. And I think when it's also a very profitable thing for the clinic to sell, it's the perfect storm. But yeah, Nandrolone makes you feel like shit. You know it exactly. Like, and that's the thing. Like, it's like anastrozole. I'm like, just some guys. I'm like, again, I wouldn't want them to take it, but like some guys just need to take it to realize and be like, oh, I inject this and I feel like shit. I'm not going to do that anymore. And I think that's just part of the process people need to go through. And I mean, it doesn't surprise me it made you feel the way it did. I mean, it's the progestin. That's how women feel when they're on birth control. You know, you're blocking the progesterone receptor, you're blocking the allopregnenolone receptor. And you're netting more progesterone activity in the body for men, which is often anti-androgenic. It's feminizing. You know, people think estrogen is the female hormone. I think progesterone is the female hormone. That's what causes more feminizing properties. I mean, if testosterone is the male hormone, it's progesterone that's the female hormone. So yeah, when people want to put in DECA, I'm just like, this is not going to do what you want it to do. Like what people's expectations are. If we look at the difference between expectation and reality of TRT, DECA, it's like way worse.
Yeah, 100%. Well, I think that was an awesome talk. It probably opened up a lot more questions than it did answers, which is fun. You know, I think because this whole space is a lot of that. You know, it's a lot of nuance, and I love that we touched on a lot of these kind of, I don't know, topics that need to be, explored. So it was awesome. I'm looking forward to part 3, 4, 5, 6, 7, into the future. Anything new on the docket for you since we've seen you last? Did that book come out?
It hasn't come out yet. So I had to move to Thailand. I had some visa issues. So I'm actually finishing off the book this week and next week. So I've got a new website on the way, which I'm really excited about. I've made it this far in my career using a website one of my clients built me, and a photo from a wedding with my ex-girlfriend cropped out from before I started this business. I'm long overdue for a media kit. So I've got a great website designed by friends of mine who I used to work with in marketing, and I've got a new photo shoot coming out, which is really good. And that will all kind of coincide with the book. I'm also, we spoke about some stuff off air that I'll announce a little bit later on my Instagram, but I've definitely got some cooler stuff coming up. It's just been announced. I'll be giving part 3 of my War and Masculinity and Your Brain on Testosterone talk at the Silverback Summit in Austin. I believe that your fine self is going to be there as well. Adam, is that correct? Yep. Yeah, so we'll be hanging out there. We're going to give a co-presentation on the synopsis of the final season of Lost. Right. I've got some theories to discuss, and but yeah, new book coming out soon, and I'm really excited for this book. It's literally the reason why it's taken me longer than I thought to write it was because I changed my stance on a lot of things that's in the book, and I didn't want to put it out because a year later, TRT 101, I stand by every word I wrote in that book, which is impressive because this field, as you guys know, changes all the time. But with this one, this is covering pregnenolone, DHEA, fertility, thyroid, and HCG, and aromatase inhibitors. It's all the most nuanced topics, and I wanted to kind of run some experiments on myself and get some more data from clients on a few things before I was really kind of confident putting out that guide, because I feel like that to me is the book that needs to be written after the TRT. Like for me, writing TRT 101 was like, guys need to have access to an easy to understand instruction manual that they can buy for, $20. And I felt there was a need for that. And now what I really feel like there is a need for is a easy to understand guide on all the shit that confuses everyone, which is do I need to take HCG? Do I need to inhibit aromatase? Do I need to take pregnenolone and DHEA and thyroid? And what's going to happen to my fertility? I feel like they're the big issues that there's not really a consensus on. So what I'm trying to do in this book is present and go, this is my opinion on everything. So that way people can, rather than booking in a consult with me, being like, what does Dave think about this? I'll just be going, this is how I do things. This is how I look at them. These are the other approaches. And this is what I believe. And I think there's going to be huge value in that. And I'm really excited to get that out there.
Perfect. Hopefully our next episodes will kind of cover that too and dovetail on nicely with that, kind of be a spoiler to the book in a way. Yeah, man. Awesome. We'll definitely be in Austin, both Josh and I and Dave. Hopefully we can get Tom and Conrad over too. A lot of our viewers love them as PCCs at Merrick. So it'll be a lot of fun. We'll all be in Austin. So I'll link down the Silverback Summit in the description below so you guys can go try to sign up for that. If there's tickets available still, it would be awesome to get you guys out there. Yeah, we'll be discussing Lost. Did you ever watch The Leftovers yet?
Not yet. I've actually got to download it to watch next. Yeah,
you got to. It's awesome.
It's good.
Yeah.
I've got 2 endorsements on it.
Well, Adam was the one who convinced me on it. My wife and I cranked through it pretty quickly, and it's incredible. Very Lost-esque because it's the same writer. Or correct, Adam?
Yeah.
Very good.
Okay.
Another good one
my
is
girlfriend's coming over to Thailand, so I'll wait for her and then we'll watch it together. Otherwise, I'll
there you go.
Another one I really liked recently was Station 19. Did you watch that one on HBO?
No, I didn't watch that one recently. So my girlfriend hadn't seen Breaking Bad, so we just rewatched Breaking Bad,
nice.
And that was a experience.
Yes,
that's such a fucking good show.
It's so good,
all timer for sure.
Well, we will.
Yeah, there are shows like that where I'm like, I wish I could go back and watch them for the first time again. And so for 100%. Her, I was like, I'm so happy for you. You get to watch Breaking Bad. But
yeah, we'll do a whole conversation on just talking about shows one day. But Dave, thanks so much, man. We'll see you in future episodes.
Thanks for having me.